Hello, my name is Chris Paget. Welcome to the first episode of the FIP CPD Bite series on paediatric pain and fever management. This episode will provide insights on how pharmacists can effectively recognize and assess pain and fever in children and young people. By the end of this video, you should be able to explain the importance of recognizing and treating pain and fever in children and young people, describe the pathophysiology of pain and fever, identify common symptoms and initial assessment techniques to recognize pain and fever in different age groups, recognize the clinical red flags for pain and fever in children and young people, and explain the commonalities and differences between managing pain and fever across different age groups. To structure this session, we will take pediatric pain and fever in turn and provide a definition, emphasize the importance of their recognition and treatment, explain their pathophysiology, discuss their assessment, underscore important red flags warranting referral, and outline commonalities and differences across different age groups. We will start by discussing pediatric pain. Pain is a difficult concept to define as it is very unique to each individual. The International Association for the Study of Pain updated their globally respected definition in 2020. It includes two important sensory and emotional components, which we will touch on later, and highlights that pain can be experienced even without a pathological cause, or where damaged tissue involvement is minimal. In essence, it is a deeply subjective experience which is multidimensional in nature. The importance of recognizing and treating pain is even more crucial in children and young people. It was estimated in a study from the US in 2017 that over half of all pediatric emergency department visits per year were related to pain. Furthermore, a paper from 2011 estimates that chronic pain affects up to 2 in 5 children and young people. The consequences of this are far-reaching. Persistent pain adversely affects physical, social, emotional, and academic function, as well as having a long-term negative impact on pain sensitivity, attitudes, and healthcare behaviours. Though less common, overtreatment should also be avoided due to increased susceptibility of children to adverse effects. Despite this, paediatric pain remains under-recognised and undertreated, in part due to lack of experience of healthcare professionals such as pharmacists in its assessment and management. As shown on the left of this slide, the pathophysiology of pain can be broken down into two main types: nociceptive and non-nociceptive pain. We will first discuss nociceptive pain, which is the most common type. Nociceptive pain arises from the activation of nociceptors. These are specialized pain receptors sensitive to harmful stimuli, which can be thermal, chemical, mechanical, and electrical. The pathway following this activation is shown on the right of this slide. When activated, nociceptors convert these stimuli into electrical impulses, which travel from the peripheral nervous system to the central nervous system via the dorsal root ganglion, spinal cord, and spinothalamic tracts. The brain, including the brainstem, thalamus, cerebral cortex, and limbic system, process these signals to perceive the pain's location, severity, and emotional response. Neurotransmitters and other substances can actually modify this pain signal and modulate it, either amplifying or dampening it. Nociceptive pain may be further divided into two subtypes: somatic and visceral. Somatic, also known as localized pain, arises from nociceptors located in tissues such as the skin, bone, and muscles. It is often due to inflammation, tearing, or injury. It's conducted through myelinated A delta fibers to specific dorsal root ganglia, producing well-localized pain. Visceral, also known as diffuse pain, comes from nociceptors in the thoracic and abdominal organs, usually due to stretching, distension, or compression. It's conducted through unmyelinated C fibers, which enter the spinal cord at multiple levels. This results in a dull, poorly localized pain. The other, less common type of pain shown on this slide is non-nociceptive pain. This type of pain may be subdivided into neuropathic and functional pain. Neuropathic pain results from damage to the somatosensory nervous system, such as from infection or trauma, leading to nerve dysfunction. Functional pain lacks a clear cause and is strongly influenced by psychosocial factors. Taking an appropriate history from the child and/or their caregiver is key to determining a course of action. To gather history about pain in children and young people, there are several methods that can be used. Mnemonics such as the PQRST, so that stands for provocation or palliation, quality or quantity, region or radiation, severity and timing, and Socrates, which stands for site, onset, character, radiation, associated symptoms, time course, exacerbating or relieving factors, and severity, help to structure the pain assessment. As part of the history taking, you can ask about pain descriptors such as squeezing or sharp, as they can also aid in identifying the type of pain. However, it is important to tailor the language to the child's age and development. Observation is also key. Watch for nonverbal cues such as changes in behavior, facial expressions, or body movements, like guarding an area of pain. How the child interacts with parents or siblings, such as becoming clingier or withdrawn, can also provide some insight. Several tools can help quantify the severity of pain in children and young people. The images on this slide are for illustrative purposes only. The FLAC tool and the comfort score are suitable for younger or non-verbal children. For older children, tools such as the Wong-Baker Faces Scale, Numerical Rating Scale, and Visual Analog Scale may be more appropriate. However, the choice of tools should be based on the child's age, communication abilities, and individual needs. There are several red flags relating to pain that's really important to be aware of to promptly refer patients for further medical assessment. Whilst not extensive, some important features to consider are as follows. If the child has moderate or severe pain, or pain that is persistent or increasing despite the use of regular analgesia. If the child is systemically unwell, for example with fever, respiratory symptoms, drowsiness, or signs of dehydration such as sunken eyes or reduced skin turgor. If the child has features consistent with a more serious pathology such as a non-blanching rash, photophobia, hematemesis, melena, abnormal gait, or an inability to walk. If an infant is unconsolable or severely distressed. If there is a history of trauma or an inconsistent mechanism of injury that may suggest safeguarding concerns. Overall, there should be a lower threshold for referral in younger patients or those with a significant medical history. Paediatric patients are diverse, but there are commonalities in pain assessment across all age groups. Standardized tools, along with non-verbal cues, are used to evaluate pain, especially in children with limited verbal communication. Parental input is crucial for understanding the child's typical behavior. Emotional and psychological factors should also be considered for a holistic assessment. However, there are also some notable differences with pain assessment depending upon the patient's age. In infants and children, behavioral and psychological indicators like crying or irritability are key, as their ability to express pain verbally is limited. Tools like the FLAC scale or the Wong-Baker Faces scale, if they're over the age of 3, are appropriate here. Older children can often describe pain in more detail, but may downplay it due to social pressures. Psychological factors such as stress or anxiety should be considered as part of a holistic approach, with more sophisticated tools like the visual analog or numerical rating scales being suitable for this group. However, as always, the assessment should always be tailored to the individual patient's needs. We will now move on to talk about fever. Now, fever is defined by the National Institute of Clinical Excellence as a physiological response characterized by an elevation of body temperature above normal daily variation. In practice, this means that a threshold temperature of over 38 degrees Celsius is usually used. Pediatric fever is a significant worldwide concern. Evidence regarding fever incidence worldwide is variable. However, an estimated annual mean of 5.88 fever episodes per child under the age of 5 has been reported. Fever is also the second most common cause of admission to hospital in the United Kingdom after respiratory illness. Whilst fever itself is not dangerous, it frequently causes parental anxiety and can indicate an underlying infection, which is the leading cause of death in children under 5 worldwide. Prompt identification of the cause is crucial to prevent further harm. Fever is a physiological response to both infectious and non-infectious causes. It occurs when an immune or inflammatory response increases the production of pyrogens, particularly interleukin-6, also known as IL-6. These pyrogens trigger the synthesis of prostaglandin E2, or PGE2, which raises the body's core temperature set point and reduces peripheral vasoconstriction to minimize heat loss. PGE2 may also enhance thermogenesis in fat and muscle and cause shivering, especially during a rapid rise in body temperature, which can further increase the fever. There is no unified consensus on the best method for measuring temperature, but there are some basic principles which are widely accepted. Digital thermometers are generally preferred, with rectal and oral routes offering improved accuracy, though they are not always ideal depending upon the individual situation. Axillary or armpit temperatures tend to be less accurate, often reading 1 degree lower than core body temperature, which should be considered during your assessment. The child's age, preferences, and circumstances should also guide the choice of method. An accurate history taking is also essential. Important background information to consider includes vaccination history, recent travel, any analgesia that may have already been given, hydration due to the risk of dehydration, systemic symptoms, and whether anyone else in the household is also unwell. Parental perception is also crucial, as parents know their child best and their insights should always be considered. Fever is a relatively non-specific symptom, and therefore it's important to consider red flags that may indicate a more serious underlying condition, such as sepsis or meningitis. The National Health Service in the UK provides infographics that outline clinical features requiring immediate medical attention in red or less urgent assessment in orange. Whilst there are separate infographics for children over and under 5 years old, there is also considerable overlap. Generally, red flags warranting referral involve signs of airway, breathing, circulatory, or neurological compromise. There are several commonalities in managing fever across different paediatric age groups. Fever in all groups is typically defined as a body temperature above 38 degrees Celsius. An accurate temperature measurement is always essential, along with symptom assessment and medical history review to determine the cause or need for further evaluation. The risk of dehydration is significant across all groups and should be assessed and managed accordingly. Additionally, parental concerns should be heard and addressed. However, the management can vary by age also. Infants and young children are at higher risk of serious bacterial infections and often require medical treatment, which would indicate the need for referral. Assessment can be challenging due to non-specific symptoms such as excessive crying and irritability. Rectal or axillary temperature measurement is recommended, with axillary preferred as it's less invasive. Tympanic measurement may be suitable for patients over a month of age, as their ear canals are typically large enough for accurate readings. Older children and teenagers, on the other hand, can often describe their symptoms such as headache or sore throat. Viral infections are more common in this group, but also the possibility of adult-like conditions such as autoimmune diseases should be considered. Oral or tympanic temperature measurement is preferred in these patients. In summary, pain and fever are common in pediatric patients, but are often under-recognized and undertreated. Conversely, overtreatment may lead to unnecessary side effects and complications. Effectively managing pain in children is essential because untreated pain can lead to significant long-term consequences both for the individual and public health, such as children refusing important medical procedures such as vaccinations. Pharmacists play an important role in ensuring that pain is recognised promptly and managed in a balanced fashion to prevent these negative outcomes. Paediatric patients are a diverse group with varying needs. Various techniques and tools are available to aid in undertaking an individualised assessment. Parental input is crucial to this assessment and should never be overlooked. In the next episode, we will explore management strategies for pain and fever across different paediatric age groups, including practical advice for pharmacists.